Dr. Jay Bhattacharya, welcome to Dad Saves America.
Thank you, John, for having me. It's a delight to be here.
You're a professor of health policy at Stanford University. I think most famously, you are a co-author of the 2020 Great Barrington Declaration, which was essentially an alternative perspective on what we should have been doing with COVID policy. Your background includes an MD and a PhD in both medicine and economics, all at Stanford. So you're a Stanford man. How do you understand what's going on here culturally inside of your field?
I think, John, I've come to see it as a broader thing than I'm about to tell you. But I'll just tell you what I think it at least is, and then maybe we can talk about the broader thing later. During the pandemic, there were two competing norms of conversation and discussion, public discussion. First, there's the norm of public health. In public health, there needs to be a unanimity of messaging, right? So, if I, as a Stanford medical school professor, come out and say, smoking's good for you, I've committed a sin. I'm doing something really, really wrong. I'm going to convince people of something that is so clearly against the scientific evidence that will end up harming them if they believe me. Right? So there's an ethic of even academics need to be careful about how they speak about public health matters because the public is listening.
Okay.
And then on the other side, you have the norm, the ethic of academic freedom, of science, of free discussion. You need to have the ability to tell even, the top scientists that they're full of BS because they might be. The free exchange of ideas is absolutely central to the progress of science. And in principle, tenure is supposed to protect you against that. Now, more broadly, tenure sometimes doesn't do that. In fact, what it often does is there's this sort of I want to fit in more. I want to climb the social ladder even after I get tenure more. And if I criticize the high guy above me in the social ladder, I'm going to get kicked off the ladder. I'm going to be put down a rung or two, right? If I don't comply with what the NIH, the National Institute of Health, wants me to, the sort of the paradigm they want me to think when I apply for a grant, I won't get the grant, right? So there's some other mechanisms of social control within academics. But in principle, it should be possible to say to the world at large, this scientific idea is wrong, and here's what the implication is, and here's what an experiment shows that contradicts what the conventional wisdom is. That's how science advances. So you have two competing ethics in the middle of a pandemic. On the one hand, you have the ethic of public health messaging, which is unanimity, and on the other hand, you have the ethic of science and academics, which is freewheeling discussion. And they clashed during the pandemic. The problem is that the scientific basis for the ethical norm of unanimity of messaging, it has to be just an absolute unanimity of science behind it, right? There's very, very, very few people who legitimately, in fact, I don't know of any that would legitimately say that tobacco doesn't cause lung cancer, right? And so there's an ethical basis for the ethic of unanimity of messaging in that setting. But we have a pandemic when there's a tremendous amount of discussion, a tremendous amount of questioning about the policies and the science for a new virus that's come up out of, come up out of not nowhere, but, we can talk about that too. But the point is that, of course, we don't have unanimity in science because the science has just started to look at the thing. And so on what ethical basis could there be to say there must be unanimity of messaging in public health when you don't have the scientific basis for that?
All right, real quick. If you like what you're seeing and you want to see more, be sure to hit the like button, subscribe to the channel, and ring the bell. It lets YouTube know that you want to see more Dad Saves America, and it helps spread the word. So it's one of the best things you can do to support what we're doing. And now, back to the show. So I want to read a little bit from the opening of the Great Barrington Declaration. I was tempted to read the whole thing for those that hadn't seen it, but I'm not going to do that. You should, we'll put a link to the Great Barrington Declaration in the comments. And then I want to come back, because to me, trying to understand who and how to trust medical expertise has become so damaged as a parent in particular. What should we do for ourselves and for our kids has gotten so scrambled in the aftermath of COVID that I don't know how we're going to recover. And I hope we'll spend a lot of our conversation talking about that. But first, so this was published in October of 2020, and it reads, just the first opening sort of declaration. As infectious disease epidemiologists and public health scientists, we have grave concerns about the damaging physical and mental health impacts of the prevailing COVID-19 policies and recommend an approach we call focused protection, in capital F, capital P. Coming from both the left and right and around the world, we have devoted our careers to protecting people. Current lockdown policies are producing devastating effects on short and long-term public health. The results, to name a few, and this was in October 2020, include lower childhood vaccination rates, worsening cardiovascular disease outcomes, fewer cancer screenings, and deteriorating mental health, leading to greater excess mortality in years to come, which I believe has played out. With the working class and younger members of society carrying the heaviest burden. Keeping students out of school is a grave injustice. Keeping these measures in place until a vaccine is available will cause irreparable damage, with the underprivileged disproportionately harmed. And what you go on to explain, and please correct me if I mischaracterize this in a summary, that as of October 2020 was that COVID-19 was essentially no more dangerous to our kids than influenza. In fact, it appeared to be less so. And that its primary risk factor was for people who were relatively old with severe pre-existing conditions. So if you were in your 70s or later, maybe you can push that down to 60s. But if you were basically of retirement age and had other conditions such as heart disease, diabetes, et cetera, you were at risk. And so what we should have done with our scarce resources is do everything we could to protect those people, including making sure that the medical professionals they might be interacting with have gained natural immunity through exposure to the virus, and basically let everyone else go about their life as usual. The kids should go to school, soccer games should continue, even basketball games indoors should continue. Basically, life should go on as normal. We should achieve herd immunity. We're going to get there anyway. Is that a fair characterization of what the proposal was?
Yes, that is a fair characterization. I mean, it's striking the way that you put it, John, because the way that people like Tony Fauci put it was he read the same thing you did and called it a let it rip proposal. But I don't see how that's a fair reading of that. What we were arguing was exactly what you said. How could we better protect older people? We'd already failed at that in October, right? We had sent COVID-infected patients into nursing homes. That happened around the world. If the principle of focused protection had been in place in March of 2020, no one would ever have thought to send COVID-infected patients to exactly the place where the most vulnerable people lived. Instead, the idea of was that we have to stop this disease from spreading by any means possible, even if we harm the poor, even if we harm children, even if we harm the working class. And that's exactly what we did. It was like trying to stick our finger in a dike and the water comes just, is pouring over it. It was a strategy doomed to fail in its own aims, which is to protect people against the disease. Tremendous numbers of older people died anyways. And it was almost tailor-made to harm the futures of our children, harm the futures of the poorest people around the world. There were estimates already by October 2020 that 130 million people were thrown into starvation as a consequence of the economic dislocations caused by the lockdowns worldwide. It was an immoral policy, and that's why we had the grave concerns we had, and that's why we wrote the declaration.
I want to just point out that you were not alone. You co-authored along with Dr. Martin Kulldorff, a professor of medicine from Harvard, and Dr. Sunetra Gupta, who is a professor of epidemiology from Oxford. So Harvard, Oxford, Stanford. You didn't lack for credentials. Now, I'm trying not to lose my mind as I recount these things. The thing that was so weird for me, it seemed like pretty quickly we knew that this thing wasn't as bad as it looked. how I was revisiting my own Facebook posts, and as early as March, I was like, because we were all bored sitting at home and scared and reading all about this stuff, and I had sort of come across that it looks like what Sweden is appearing to do is probably what we should all do. But what was known then? Going into this thing, what was the state of the art in response to something like this? There had been SARS viruses in the past. Asia had suffered through multiple SARS pandemics. So what was the common knowledge in 2019 that did or didn't survive into 2020?
So the pandemic plans, the civilian pandemic plans, did not envision a lockdown of society at large. Nothing like what we did. The civilian plans emphasized local infection control, quarantining the unhealthy, maybe screening for fevers in high throughput areas and so on. That's how the first SARS pandemic was managed. Actually, I don't think if we'd done exactly that, I think we would have done much less harm. And I think the disease would have spread marginally more quickly, but I don't think a palpable difference would have been made in disease spread. The main thing that we knew in 2019 was we needed in the civilian plans was we needed something that was tailored to the specific epidemiology of the disease that was spreading, and also that was mindful of the fact that you have to allow people to live their life, or else if you disrupt it, you're going to cause more harm than good. Just from a health perspective, never mind the economy. That was my understanding of the civilian plans for public health management of a respiratory virus pandemic in 2019. When the pandemic hit, it was very clear from the earliest data that was coming out of China that there was a very steep age gradient in the risk of dying, where and it's exactly as you said, John, young people, children especially, were at a very low risk of dying if they got infected. Again, from the very early days of the pandemic, lower than the flu. Whereas for older people, it was a much more deadly disease than the flu. Older meaning, and there's no like single age threshold where you say, okay, it's a risk for above and not a risk below. It's every 7 years of age, the risk doubles. So for 50-year-olds, in 2020, early 2020, if you got infected, the mortality rate was roughly 2 out of 1,000. If you were in your 80s, 90s, it could be 5, 6, 7, 8%. It could be a very, very significant death rate. If you were a child, it was 1 in a million. So you had this very, very distinct age-related gradient in risk, and that was known in December of 2019. I first saw those data, I think, in like late January 2020. And so I knew for certain. Martin Kulldorff tried to publish a piece in early February 2020 where he wrote up this age gradient and couldn't find a publisher for it. He ended up putting on his LinkedIn blog. This is a Harvard statistics professor, epidemiology professor. And so that was known very early. What wasn't known in March of 2020, I think, was two things. One, how widespread was the disease already? How effective had been the infection control measures that had already been taken in stopping the disease from spreading? And two, what was the average infection fatality rate? So I wrote an op-ed in March of 2020 in the Wall Street Journal. It's the first time in my life I ever wrote an op-ed. I used to just write scientific papers for a living. And the op-ed said, we don't know the answer to these two questions. And it's critical, right? Because if we're in the middle of locking down the entire world, causing untold economic harm and catastrophic damage, public health damage to the poor, we close schools, which was certainly going to harm the future of our children. Was there any real warrant for it, even leaving aside the harms of the lockdowns? If the disease had already spread everywhere, had been seeded everywhere, then what was the purpose of the lockdown? If the disease had a low average infection fatality rate, it would then what we needed to do was focus on the people that are highest risk, the older population, and protect them. And so I wrote this op-ed that led to my actually running a study measuring how many people had antibodies to the virus in April of 2020.
Okay.
In Santa Clara County, California, and then Southern California and LA, we found the same answer. Roughly 3 or 4% of the population already had the virus, which doesn't sound like a lot, but actually we'd just been in a lockdown for a month and some, and there'd been there's no like from like first glance, it didn't seem to have stopped the disease from spreading, which is now not surprising given we know it spreads by aerosols and it spread very easily. And then two, the disease, the infection fatality rate was 2 out of 1,000 overall in the population. That's the number we got. A whole bunch of studies came after us with independent research teams from around the world that replicated that result. Ours was right smack dab almost in the middle of all of the other studies that have looked at this. The disease had already spread, and there were, for every person who had been identified as a case, there were 50 people or 40 or 50 people walking around Santa Clara County, California, or LA County, California, who had antibodies that public health knew nothing about.
Okay.
It really was like sticking your finger in a dike, right? We were like, oh, we've stopped the water coming out of that hole when the water was spreading around all around us.
I want to slow this down for a minute and really make sure I'm gonna wear my maximum innumeracy hat, because frankly, fractions are hard. They're hard for us to hold in our head. We hear these things like, I don't know, 0.04 parts per million of carbon dioxide, and we're told that's supposed to be a lot, but it's parts per million, which doesn't sound like a lot, but I'm told it's a lot. I don't know if it's a lot. So what do I, if I wasn't good at math, I actually was good at math, but leave that aside. If I wasn't good at math, how do I understand what you were measuring and what I was hearing in the news then and might hear in the future, so that I can understand what you were trying to get at? I remember early on there was talk that the fatality rate might be as high as 3%. I might be misremembering that, but
No, that's right. 3.5% was the WHO said.
So that's scary. That's 3 to 4 in 100 people in a room. So I go in a room with 100 people, 3 or 4 of them are going to drop dead of COVID. That's pretty scary. That could be me. That could be my kids. What did your research do to change the numbers there? Like, really lay it out for me, like, step by step.
Sure. So the key thing, okay, so that number that WHO said, WHO in February 2020 says 3.5% mortality rate, right? That is exactly like you said, John, a catastrophically high mortality rate, right? So my high school had 2,000 people. That meant if 3.5%, we're talking like 70 people are going to die that I know.
Yeah.
Right. And you know way more than 2,000 people. I mean, 3.5%, you're going to notice a very large fraction of people in your own circle, a large number of people in your own circle are going to die. That's a catastrophically high number, right? So that number, it's lower than smallpox, which, like, the worst form of smallpox would kill 30, 40, 50% of the people it infected. It's lower than SARS-1, but it's higher than the flu, much higher than the flu, right? The flu, I don't know exactly what the infection fatality rate is of the flu. And now that I look back at that research, it's not so good, but it's on the order of 30, 40, 50, 60 times higher than the flu. That's a really bad number.
Yeah.
The problem with that number, John, is that that's based on people that are identified as having COVID at a time when there was very few testing resources. There were very few people that were being tested for COVID. All of the testing resources were used on people that were in the hospital, that were very, very sick, suspected of having COVID, because that's how you do medicine, right? You want to triage it for the people that most need it. For an epidemiologist looking at that, what that means is that the measure we have, the denominator, is a very select sample of the set of people who actually have COVID. We're not going to find the people that have had COVID and recovered and didn't go to the doctor, that didn't get tested.
So this is basically a confirmation biased denominator. Like, oh, out of the people who said they've got the sniffles all the way to they can't breathe, 3.5% of that group are dying.
Exactly.
Not
right.
3.5% of anyone I randomly stop and shove something up their nose at the intersection of the shopping mall.
Right. And in fact, what that meant is that we only had a very narrow, blinkered view of the pandemic as of March of 2020. And the WHO and the media and the CDC and the governments around the world were ringing an alarm bell based on that number that was very clearly an overestimate of the risk that the typical person would face if they were infected.
The other piece of storytelling that was out there at the time, setting the stage, was complex mathematical models projecting millions of dead by a guy named Neil Ferguson, if I remember right. He was this physicist out of the UK.
Imperial College, London. Yeah.
And there was even a Nature article, which I pulled up before this just to try to reorient myself. Like, how seriously was he being taken at the time? And there was a Nature article saying the modeler who's defining COVID policy for the world, Neil Ferguson. What was he getting wrong?
Okay, so he is as a modeler, epidemiological modeler with a physics background in Imperial College London. He estimated that within 2 months or 3 months, some very short time period, that if we did absolutely nothing in the United States, that 2 million people would die within that very short period, March, April, May 2020. He estimated that 500,000 people would die in the UK. Someone took his model and applied it to Sweden and estimated that 100,000 people would die if they did nothing. The model was based on a whole series of guesses, right? It guessed that the infection fatality rate was 1%, when in fact it turns out to be something like 0.2%. It was off by a factor of 5. The model guessed how easily would the disease spread. It had embedded in it assumptions about how people interact with each other, right? So people just randomly interact with each other and the disease can spread if you have a random interaction. It has embedded, built into it as an assumption, the idea that if you keep people apart, lockdown so that you keep newborn babies away from moms, you keep parents away from their kids. If we just keep them physically apart, that's going to reduce the risk of disease spread, right? It had none of the harms of doing that in the model.
Right.
But human societies aren't structured that way, right? Poor populations, for instance, live in much more crowded circumstances. You can't keep them apart without any. So, for instance, there was a study done in Mumbai, in India, in July of 2020 that found that 70% of people had already had COVID in the Mumbai slums, but 20% had had it in the richer parts of Mumbai. Right? This is July of 2020. But the model had this sort of embedded in the assumptions, the idea that if we keep people apart, you're automatically going to save lives. And so it predicted 2 million people were going to be saved if we locked down. The prediction was built into the assumption of the model. I actually got to meet with President Trump in August of 2020. And one of the things he asked me is whether he had saved 2 million lives by locking down the United States. And he'd gotten that number from the Imperial College model. Right? That was a tremendously influential model for the leaders of the world, but it was based on faulty assumptions, and the structure of it was I think questionable. And probably the worst of all is that it did not mention the harms of the policies it was inducing governments around the world to adopt at all.
So this is this common fallacy, right? The seen and the unseen. What's shocking to me is that this only measure the costs, not the benefits thing was being done by the elite of the elite, or so we are supposed to believe. This is the heights of public health, the heights of physics and advanced complex systems modeling and the World Health Organization. So, meanwhile, you go out there into the world and you just start testing people and find that the denominator assumptions are wrong, that the fatality rate is obviously wrong, and that gets replicated quickly. And that's early in 2020. So why is it, in your opinion, that that's happening not just with you? I remember I think the Germans conducted a similar thing and found that, wow, like 15% of people in Berlin already have it. How is it that by the time the Great Barrington Declaration is published in October, the so-called experts haven't realized that, wow, we're a little too fast off the starting block with our models? Like, what's going on in our information system that it adapted so slowly when it was so important to get it right?
I think in a word, it's hubris. I think that the experts that were leading the public health response were so certain that they were right that they couldn't see the evidence in front of them that they were wrong, and in fact acted in ways to destroy the careers of anyone who disagreed with them. I wrote this study in April of 2020, this Santa Clara seroprevalence study is called, measuring how many people have antibodies, and with the result that it's already pretty widespread. After I wrote that study, there were hit pieces done on my wife by BuzzFeed, false allegations that I'd taken money and altered the result of the study. I've taken $0 for my COVID-related work. I feel it's unethical for scientists, unless you have to feed your family, I guess, to take any extra money for their work on the pandemic. I had to hire lawyers. It felt like an inquisition by my own university for the crime of conducting this study, which they eventually said I did nothing, but never publicly released the result of their inquisition. I call it inquisition. They called it a fact finding, but it felt really bad.
We went on a fact finding mission to see if one of our most prominent professors in charge of conducting health policy research conducted health policy research.
It was surreal. I was quite upset at Stanford because I've been there now almost 40 years, and it was such a shock to me. I love the place. I've grown up in this place, become an adult really in this place, and I couldn't believe that it was acting in the way it was acting. I almost left in 2020 in anger over this. After this experience, I think that anyone who found results or spoke against the government's preferred policy response then was seen as a heretic. It did not feel like a scientific environment. It felt more like a cult. And we're just saying, you guys, this is not right. This is, you're just doing normal science. And the cult response is, you're a heretic. You have to be excised from the community. And I think that characterized the response of the leadership of the scientific community and the public health community almost from the beginning of the pandemic on.
Do you credit your time as in studying economics to helping you navigate this? Because it feels to me, I forget who it is. It might have been George Sigler out of Chicago, or I'm an econ nerd. But I've heard the phrase, the only real social science is economics. The rest just pretend, something to that effect. It's probably not exactly true, although I tend to say social science with scare quotes for a reason. Did economics, which focuses on costs and benefits and weighing them at all times, was that like your superpower in this moment?
For me, it certainly was useful. I had been studying the economics of government policies and markets and the impact it has on the health of vulnerable populations my entire career. My first instinct when I heard of the lockdown was, what's going to happen to the people who live in the slums of India, right? What's going to happen to the children living in households where they have abusive parents and they can't go to school where this abuse would get picked up? Mm-hmm. What's going to happen to women living in abusive relationships? Those were my first thoughts because I've been studying them my entire career. I do think, John, just to like in fairness to the other social sciences, many of the people that spoke up against the lockdowns didn't necessarily have economics background, but did have a social science sensibility and understanding that the living circumstances of the people of the world are tremendously varied. There are a tremendous number of vulnerable people, poor people in the world, and that they can't abide a lockdown. That the lockdowns were a luxury of a certain class of very privileged people, mostly in the developed world, maybe 20, 30% of the American population, who wouldn't lose their job because of a lockdown. And that, I call it trickle-down epidemiology, John, right? The idea is that, if you just have you protect the top strata of society, the rich, then everyone else will benefit from this epidemiologically. It was a folly to begin with, and it was clear to me, and I think anyone who took the lessons of social science and economics reasonably would have come to that same conclusion.
The whole thing, to summarize, looks like the agencies and political leaders, both partisan and less so, ignored everything that prior to the pandemic was understood to be the protocols for dealing with this exact thing, took the most totalitarian, draconian measures imaginable and applied them to most of the planet, in spite of the fact that it was obvious to anyone that thought about it for real that this would be a disaster, and in spite of the fact that esteemed people in the field, like yourself, had already laid out that their fundamental assumptions were wrong. And then months and months and months and months, and even to some extent to this very day, these same people went on a witch hunt to silence anyone that would point out the fact that their emperor, that they have no clothes as their public health emperors. Is that fair?
That's entirely
Condemnation?
fair. I mean, it's depressing, but fair. I mean, let me just say that I think that you can say it in two phases, and maybe the motivation changes between the two phases. Phase one, we don't know. And so when you don't know, you could try to learn and then assess. There's a principle that sometimes is used called the precautionary principle. It has its problems, but like may be useful in such situation of fundamental uncertainty, right? So we don't know what the risk is. We're not exactly sure how it spreads and so on. What you do then with the precautionary principle is say, well, let's assume the worst case.
Yeah.
Right? Let's assume that the infection fatality rate is actually 3.5%, not 0.2%. I think that's not an unreasonable heuristic in the face of a big risk. But what you're not allowed to do in the context of the precautionary principle is say, the thing that I'm doing to try to address the risk, to mitigate the risk, will automatically work. You're not allowed to make that assumption. You may be allowed to assume that the thing is really risky, but you're not allowed to say, if I pull my hair and tap my nose, the disease is going to stop spreading, right? That's just not allowed in the heuristic. You're not allowed to say that the thing that you're doing has no harms, especially when you know for certain they're going to have harms. And you have to take into account everything that you do actually know about the risk, the disease, the age gradient and risk, for instance. The precautionary principle, all it buys you is, while we're still learning about this uncertainty about this particular area, I can assume the worst about that thing. But everything else, or the entire framework of economic evaluation of policy, still should apply in the context of the precautionary principle. Right? What are the risks? How likely is it that I'm going to be able to mitigate the risk with the thing I'm doing? What are the harms of the thing I'm doing? Are there other things I could do that would mitigate the risk better with fewer harms? Right? Those are all things you still have to ask, even if you assume the precautionary principle. So I think in the first bit, that was the issue, was like the uncertain, just sort of a failed way of thinking about the precautionary principle. Over time, as it became clearer and clearer that the public health establishment and the expert class had led us down a path that was just destructive in a way that I can only talk about war as an analog of being as destructive. That it became an element of it became a thing for preservation of reputations rather than anything else. Right. So now you see Tony Fauci getting awards for a failed response to the pandemic. It was just a catastrophic mistake. And at this point, the only thing that's left, I think, for the leaders of the pandemic response to do are, I think, if they were honest, they would go in front of the public and apologize. But if they were to do that, they would lose their positions. And so they're not doing that. Instead, they are working to try to protect their reputations.
So I have very strong biases here that I can't help but state, which is I don't particularly want the government to do much of anything. I am economically very much a libertarian. And so when I hear about government screw-ups, there's a part of my confirmation bias, my ideological excitement that sort of kicks in and says, see, I told you this was all a scam. A bunch of crooks and cronies trying to rip us off and line their pockets while they treat us like something between dairy cows and veal. That seems to be closer to honest political economy coming out of COVID-19 than any other model for what the government should do, right? I guess infectious disease was the one area that I thought, even as sort of Mr. Libertarian guy, it's like, well, if you have a global airborne disease where it's going to be really hard to coordinate people and people can move across borders and get on airplanes, it's sort of a collective action problem. This might be the one area where even a perfectly libertarian but not fully anarchist society it'd probably be okay to have the government sort of step in and say, okay, we're going to do this, this, and that because we're the only ones that can act on this. Can that defense of government possibly still stand in the aftermath of COVID? I mean, how do you actually think about what the role of government should be in public health now, and how did it change over the course of this experience?
I think public health, as properly constituted, is the attempt to address and at least partially solve exactly the collective action problem that you mentioned, Sean. Right? There are aspects of health that involve collective. My actions might impact you in the context of infectious disease. Right? So there is, in a sense, sort of a Pigouvian, if you will, justification for government intervention in the context of public health. There's also, though, it turns out, and this is not, I guess, surprising to economists of the Virginia school, that government regulatory agencies get captured. Yeah. There are, games that people inside government play that do not serve the public interest. There's government failure as well as market failure. Right, so infectious disease represents, in a sense, a market failure. If you in a way that the market might respond to infectious disease will not properly solve that collective action problem. At the same time, the government itself is captured, for instance, by a man like Tony Fauci, who's been sitting atop the head of infectious disease policy inside the government for almost 40 years. And he has a cadre of scientists that he's funded to the tune of billions of dollars a year that will move heaven and earth to protect his reputation. Because if he goes down, the reputation of they might also go down, right? Or they may have genuine fondness for him. There's a clannishness, a closed-mindedness at the center of government that has as its premise that the government knows best and the plebes don't. It's a very anti-democratic thing when you're, especially in public health. You have the two things going on simultaneously, right? And it's. I mean, it may not just be public health, but certainly in public health, you have those two things I think we saw during the pandemic. I don't personally believe that you could have an anarchist response to a pandemic. I don't think that would produce a reasonable response. That's why the Great Barrington Declaration didn't have one sentence, let it rip, right? It didn't say that. So I don't believe that. That's why I didn't say that, right? I think that there is a legitimate role for government to play in the context of pandemics. But if there's not some capacity to criticize the government from the outside, to identify government failure when it does exist, then the government's going to fail and fail badly. And you'll have both the collective action problem and the harms of the government failure, which is exactly what we had during the pandemic.
Is there a path that you could imagine that's real and not just on a blackboard for these institutions to be better than they are? Because I think the thing that has happened that is so devastating is I don't have a problem with people no longer trusting things that are untrustworthy. Like, that's a step towards truth. So I think that's good. But when really important things are untrustworthy, that's obviously bad. So where do we go from here? There's a lot of people across the ideological spectrum, frankly, who say we have to somehow get like the money out of it, that it's because of big corporations and big pharmaceutical companies who essentially bought off the medical industrial complex. And yeah, nominally these are government, like the FDA and the NIH, but functionally they're in this sort of captured state. Another side would say, well, no, that is closer to communism than capitalism, and we need more free markets. We need fewer of these agencies. Like, Is there a coherent way to think about how to get towards something like that looks like more trustworthy organizations in charge of this stuff?
I think so. There's three major organizations with three different sets of problems, I think, at the heart of public health in response to the pandemic: the National Institute of Health, the Center for Disease Control, Centers for Disease Control, and the FDA, the Food and Drug Administration. Those three have related but distinct problems. But I think the idea to fix them, and I agree with you, those agencies need to work, right? They're like, if they don't work, we see the problems. If you don't have them, there could be a whole other set of problems. It's completely reasonable to distrust them now. I distrust them now, but it's not reasonable to say they shouldn't be trustworthy. And so my view is we should figure out how to make them trustworthy. So first of all of them need to go apologize to the country and to the world, right? That would be a good first step, rather than gaslight people into thinking they did a good job. But let's just leave that aside. Let's just talk about, in principle, how one might fix it, right? So take the National Institute of Health. The central problem there was concentration of power in the hands of a relatively small cadre of scientists, a cartel of scientists, who controlled tens of billions of dollars of funding. Francis Collins, he's the head of the National Institute of Health for almost, I think, a decade or some. Tony Fauci, for almost 30, 40 years, head of NIAID. They don't just control money, the billions of dollars. They also control the reputations of the scientists that they fund, right? I have tenure at Stanford Medical School in part because I've been successful at getting NIH funding. It's the way you climb the ladder of the field, right? That turns out to be a tremendously corrupting thing. And so what happens then is scientists that know better, that should speak up, stay silent because they're afraid they're going to lose their social status.
And they're funded
to that,
right?
Yeah, and they're funded. They can't do their experiments, and they can't look fancy in front of their colleagues because they don't have the NIH money. So the way you fix that is decentralization. You allow there to be competing scientific schools even within a single field. What happened during Francis Collins' tenure as head of the NIH is he concentrated power. His model of how the NIH ought to be run was like the Manhattan Project. He was the head of the Human Genome Project, right? A major, large-scale scientific project. And for him, centralized control of science was the right way to do science. And I think it's the wrong way to do science. I think decentralization, radical decentralization of scientific, more like what VCs do in Silicon Valley, right? Anyone can do a startup, and lots of VCs will fund it, and they fund lots and lots of VCs will fund lots and lots of startups. Most of them will fail, but a few will succeed, and those will transform the world. That's the right model of thinking about science, rather than I'm Francis Collins. I know that we have to sequence the human genome, and that's the only important thing we need to be able to do in science. We can put everything else to the side. For the CDC, they seemed utterly immune to outside criticism because they're so enmeshed in this ethic of unanimity of messaging that they think that if anyone criticizes them, they're anti-public health. And, I think decentralization might work there as well. Right. So there are actually 50 state public health agencies in this country. Those public health agencies should all have much more autonomy. And when the CDC makes a guidance, it effectively has the impact of law. CDC plays this game where they'll say, "Oh, we're just making guidance. We're not forcing you to mask your toddlers." Then somebody sues and points to the CDC guidance and says, "Oh, look, masking toddlers is a good idea," as if the science is settled when it's not.
Yeah. This is one of these things that I think is very often forgotten about the American sort of legal system more broadly. Everyone likes to look at Congress and the laws that get passed and the claims about what the laws will do. But the things that any part of the government does that will help a lawyer make money in the courtroom are the law. Like, so if an agency that has a bunch of unelected bureaucrats just make a decree, and I can get sued as a business owner or as a parent or as a school administrator and lose because this unelected bureaucrat just decreed that 6 feet should be how far apart we should be, even though there's nothing to support that whatsoever. But I can now, if I don't put stickers in the line at Walgreens. Walgreens is going to get sued by some ambulance chaser because somebody got sick while they were reading People magazine. I mean, that is, that's the system we've got in this country, isn't it?
It really is. So I think, okay, so I don't know how to fix that entirely, but I have some ideas about how, at least within the context of the CDC, how to make it better, right? So one thing is that in other parts of the government, regulatory agencies, when they make some regulation, they have to go through a crazy amount of bureaucracy. There's this Administrative Procedures Act, I think it's called. I'm not a lawyer, but but the point is that if they are going to publish something in the Federal Register, it has to have public comment. It has to go through long periods of revision. There's lots and lots of eyes on it, even outside the agency. The CDC doesn't seem to allow that or do that. The way to transform the CDC is by forcing them to do the same thing that other regulatory agencies do before they publish things in the Federal Register, so that people from outside can make public comment, and they're forced to take account of the public comment before they publish something as guidance. They should be forced to go to the 50 or whatever state agencies and ask, what's your independent scientific interpretation of this question of toddler masking? And then alongside their official guidance, they say, well, 55% of the federal agencies, the public health agencies disagree with us on this, or say that the level of evidence behind this is weak. And they should use explicit language that non-scientists can understand. So when it's used in courts, that language is very, very clear about when things are very certainly known scientifically, tobacco causes lung cancer, and when they're not, which is toddler masking stops you from getting COVID, or kids from spreading COVID.
You mentioned the FDA was the third in the trifecta of disasters in our federal government that were in charge of everything. What's wrong with the FDA?
So the FDA is essentially a captured agency, captured by the groups that it's supposed to regulate, and so it makes the market worse and doesn't protect the public. In the central tension inside the FDA is, I can find something and see that it's going to kill you or cause malformed babies or something, and I can stop it. Right. So if I were to let something through that kills people and has malformed babies, the FDA gets a black eye. Yeah. Right. And so for the history of the FDA, that's been the main thing, is like they want to prevent the visible harm. And the critique has been, well, they're also slowing up the approval of lots and lots of products that ought to be approved because they're being so conservative in approval.
So just for those who aren't familiar, Jay, what you're talking about is the nightmare of thalidomide, right? When you're talking about babies being deformed.
Yes.
And that thalidomide, well, tell the story briefly, because that's the sort of landmark, this is why the FDA is so great and so necessary story. So what was that? What are you referencing there?
So there was a chemical called thalidomide that was marketed in Europe that was marketed to pregnant women as a sort of morning sickness kind of medication. It's actually it will reduce your morning sickness, right? Shortly after it was approved in Europe, there were reports of limbless babies being born, babies without legs and arms.
Right.
And it was a huge number. It was a huge catastrophe. It turns out, with some epidemiological work, to find that it was women that had been taking thalidomide during some trimester during pregnancy that caused the limbless babies to happen. The U.S. FDA actually, at that point, was considering whether to approve thalidomide for use in pregnancy, and they kind of had slow walked it. Asking for more evidence, which is actually, I thought, it turns out in retrospect, completely reasonable. Ask for more evidence from the manufacturer before approving it. And shortly after this disaster, the FDA, the Congress actually gave the FDA more power. Before that, this is like in the 60s, the FDA had the power to say no to drugs that they found to be unsafe. But they didn't ask manufacturers to prove that the drug was going to be efficacious again in treating some disease. After this, there was the Kefauver amendments in the 60s. The FDA had the power to both require that the manufacturers prove that the drug is safe and also that it's effective for treating at least some disease. That's
Right.
post-thalidomide.
So
Actually, there's
that's
an irony. There's an irony. I don't know if you know the end of this thalidomide story. It's really interesting because thalidomide is now approved by the FDA. It turned out to be really useful for treating wasting disease in HIV patients. And
I remember reading
I mean,
this. I remember reading this a while back. That's right. In fact, that thalidomide was sort of back on the table for other uses.
yeah, just don't give it to pregnant women, right? So, like, fundamentally, there's an uncertainty. There's just stuff we don't know about drugs, and it's a complicated thing to like regulate it.
It's one of the things that's so interesting and weird about that moment. And I actually think this connects into the present and where I'd like to go next perfectly, which is whether the safety component of that, which was what the thalidomide blocking, was good. It was they even if they're a broken clock that's right twice a day, they were right on that one. That actually doesn't have anything to do with the efficacy part. And it's so weird that they would be given a tool that turns out to actually not be good for them, which is proving that the drugs will work, as opposed to just proving that they have some level of safety. And what's happened now in the aftermath of COVID and the vaccine mandates is that a lot of things that prior to COVID, I think were at least I understood to be, here's how we make our public health better. One of which being repeal that requirement at the FDA that they prove that things are effective. Like, it seemed like let the marketplace, let people and their doctors decide for themselves whether something's effective or not. Don't prevent someone, especially people who might have a terminal illness. Frankly, if you have a terminal illness, you should be able to have anything you want. You should be able to just try whatever you can try. And there's these right to try laws now. But what's happened is the things that would have been positive reforms at FDA and the people politically who would have been more inclined to say, yes, we should have these reforms that will make the FDA looser, have now become so skeptical of all of it that the idea of faster approval of drugs, I don't even know who's for that anymore. I don't even know, like, who in our politics wants drugs and medical procedures to get approved faster? How do you think about this political transformation that's happened? And I want to pivot into vaccines from here. So
yeah, I mean, so just on the regulatory matters, I think it was like 2016, 2015, right before the Obama administration expired, there was a bipartisan approved law called the 21st Century Cures Act that actually made it easier to get drugs approved inside the FDA, right? Rather than show efficacy, meaning I have to show that my drug saves lives, I can show that it just produces antibodies or something. It can have intermediate endpoints and gain approval, faster track approval for drugs that have a big use. I think that that's not an unreasonable thing to ask for, right? So, but there has to be a flip side to that, which is that if you have approved a drug relatively quickly and ex post, you're actively looking for side effects and warnings, limbless babies or whatnot, you very rapidly say, look, don't use this thing in pregnant women. Take this drug off the market because it's killing people in ways that we can't control. I mean, you have to have both parts of the equation for the public to actually be protected by this agency. Right? Yeah, because ultimately there's an uncertainty. Neither the regulator nor the drug company nor the public knows exactly what this drug is going to do. Right? And when you learn by people taking it, right? That's really if you can take it in systematic ways, like in randomized trials, you're liable to learn quicker than if you don't. After you've approved it, you need to be looking. So there's never going to be a perfect solution because at the heart of it is we're not God. Right? We don't know if this drug, what exactly it's going to do for every single human being, right? Doctors have practice an art because they always, whatever you give somebody, there may be some harms and some benefits, and you're hoping that the benefits outweigh the harms, right? So, and the knowledge of the doctor has for patient allows them to tailor the message so that it's a combination of the science around the thing you're telling the patient to do and the reality, the story of the patient themselves. Right, so that it's a complicated thing. It's just at its heart a complicated thing. But there's no omnipotent God sitting in the room of Tony Fauci that allows him to know the difference between a good, safe product and an unsafe product, or the FDA. Right. So you have a difficult problem. What's happened with the capture of the agencies, and I didn't really understand the capture really until the pandemic, is that the pharmaceutical companies, first, they pay for a lot of the activities of the FDA. That's legal. There's a law called the Prescription Drug User Fee Act that allows drug companies to pay for the activities of the FDA. The 21st Century Cures Act and other regulatory reforms have made it much easier to get drugs approved. And I worked with the FDA for a decade on safety before the pandemic. It's very difficult. The FDA scientists are very conservative to call a drug unsafe, to issue a black box warning. It takes a lot of evidence, a long time before they're willing to do that, much more conservative than I think they ought to be. And so it's just very, very unbalanced. And you saw this during the pandemic. With the vaccines, I think it was a reasonable case to make that the vaccines ought to have been recommended for older people, even though the randomized trials themselves did not check to see if it prevented you from dying. Right? That was not the primary endpoint of those trials. It was reasonable to say, look, it prevents you from getting symptomatic illness. And for older people, getting symptomatic illness is a really high risk of dying, just as we talked about earlier. And so therefore, the benefits of this, even though we don't know all the full set of side effects, are likely to offset whatever potential harms there are to older people from taking it. It's reasonable to request that.
I want to make sure I understand the part of what you just said. The trials, the tests of the vaccines did not check to see if they prevented death. Did I hear that correctly?
Yes, that's correct.
What does that mean? Is that because... Why would... Wait, what?
Yeah.
Is that just because of the time frame that you couldn't know? I don't think I understand what that
part
means.
of it. So the key thing is that it's not that deadly a disease. 0.2%, 2 out of 1,000, right? So you would have had to enroll, 1,000,000 people in order to address the question, what does it actually prevent you from dying? Because you need to have, in a randomized trial, you have one arm that gets the vaccine or whatever, the drug, and one other arm that doesn't.
So you need some statistically significant sample of the population that would say, okay, it's not just like, it's inside the margin of error, I guess, right, is what you're saying.
Exactly. And so if you have a very rare event, you need a very large number of people to get a sufficient number of those rare events. So just to give you an example, the trial to demonstrate the effectiveness of the polio vaccine that Jonas Salk ran in the 50s, it enrolled something like 1.8 million children because paralysis after polio infection was a rare outcome. So you needed a very large sample size. So the trials, as they were constructed, instead of having mortality, which is a rare outcome, it had prevention of symptomatic infection, which was not a rare outcome. You could then get away with enrolling only 40,000 people for the trial rather than 2 million people for the trial. So we knew in December 2020 that it would prevent you from getting symptomatic infection for 2 months. Why only 2 months? Because we're in the middle of a pandemic. People really want the vaccine. I would love to have had a much longer trial, but you can understand why they would do it for a relatively short period of time.
Yeah.
Okay, so 40,000 people sounds like a lot of people, but then when you recommend that 300 million people take it or 2 billion people take it, you're going to find side effects that were not in the trial of 40,000 people because 2 billion is so many more people than 40,000.
Well,
and you're going to find things.
Well, and you also, when you start to slice and dice 40,000 people along age, gender, like regional genetics or race, although I think regional genetics is probably a better way to think about that. other drugs that you might be on, other diseases that you might have, whether or not you have this disease and this drug, all of the one of the things that's interesting when I think about these complex problems is, there's a show that came out on Netflix recently, The Three Body Problem. Have you seen this show? Are you familiar with it?
It's based on a book, right? Or am I thinking of the wrong thing?
I think so, but it's like about aliens and stuff. But the thing that
I just saw that book. It's like there's a famous science fiction book.
Is crazy because apparently I didn't realize this, that if you have two celestial bodies, the Earth and the Sun, you can use the math of their shared gravity to calculate predictably, reliably, the way the Earth will move around the Sun, and it actually doesn't move around the center of the Sun, but very slightly off axis. All you have to do is add a third body, and the math can no longer predict the outcomes. That's the three-body problem. You add Saturn. I mean, in our solar system, it depends on the weights and stuff, so our solar system is predictable, but if they're big enough and close enough together, the three-body problem means three variables is all it takes for total unpredictable chaos. And yet here we are with all of the different things that constitute variables for whether or not a drug is going to work well. Right? I mean, is that a decent way to think about just how challenging this problem is?
It is. It's an incredibly complicated problem, especially since people are different from each other. In genetics, yes, but in terms of like the way they've lived their lives, the million different ways. This is why medicine will always be an art, right? There's always the question of, is the person that you're seeing as a doctor, is that person different than the person that were enrolled in the randomized trials? There's an application of the result of the studies, which is like an average for a population that's typical for randomized trials, to the person that the doctor is seeing. It has to be tailored, and there's always going to be uncertainty, and there is no way around that fact. No AI, nothing will ever get around that fact. It's just propaganda of medicine to pretend like we've solved that problem. It's an unsolvable problem. It's always going to be an art.
I try to see every big issue through the lens of what we as parents can do and where our agency lies in the issue. Because there's a lot of people that talk about politics and policy, and that is what we've been talking about. But this gets really personal really fast, and it comes down to questions like, should I vaccinate my child or myself or my spouse? Should my spouse get vaccinated? Should we both? And then which vaccines? And should I trust vaccines as a general technology? Should I be distrustful of them as a general technology? One thing that's so interesting is Marin County, California, coming into the pandemic. The New York Times did an article on this. I've spent some time in Marin, so I will anecdotally back this up. Marin County, super crunchy, super left, home. New York Times called it a haven of anti-vaxxers before the pandemic. Post-pandemic, because of the way the politics became, it had the highest vaccination rates in the country. So that's weird. What should I do? How should I think as an American about vaccines and whether they are good or not? Where do I turn so that I'm not listening to crackpots and cranks? Because there's crackpots and cranks everywhere, including at the heights of the medical establishment, it appears.
That's a tough question, right? So let's just stick for right now with the COVID vaccines. Right. So that if there had been an open discussion allowed around it, that it would have been very clear, I think, to most doctors and most parents that the benefit of the vaccine, for the COVID vaccine, for young people, especially children, was very, very small. Why? Because the mortality risk of dying from COVID for children was very, very small. So it's you reduce a small mortality risk to an even smaller mortality risk, you're not getting very much benefit. That is enough to say that any possibility of side effects in that group would lead you to say, don't use that product in that group. In fact, Martin Kulldorff and I wrote an op-ed in The Hill, I think, in April of 2021, recommending against younger people taking the vaccine for that, with exactly that reasoning. There were evidence coming out already around then that young men especially got high rates of myocarditis and heart inflammation when they took the vaccine, with the COVID vaccine. And so the question then is, what benefit is there to my child from taking it? That's the first question.
Yeah.
Like if it's potentially large, then you want to consider it. If it's not potentially large, then you want to be more careful about it. The flip side of for the older population, there's a much higher risk of dying, and you're reducing the risk of getting sick with the disease. You're probably you have a much wider range of like how much benefit there could be, and you're going to be willing to allow there to be. I should speak for myself personally. If I'm going to gain a lot of benefit and expectation, and I'm going to be willing to take some risk, I'm going to allow there to be some potential harms, especially if they're low risk. Low probability, and I'll still take the thing because I expect to have more benefit than harm, right? So that's the base of the recommendation for older people to take the vaccine. If somebody tells you that there's a uniform risk, and you know there's not a uniform risk, if somebody exaggerates to you the nature of the risk on either side, taking the vaccine or not taking the vaccine, and you can get a sense of like, are they alarmist? Are they reasonable? Are they balanced? Are they accounting for other people disagreeing with them? What do they have to say about the people that disagree with them? Then you should be very careful about believing them about the nature of the risk that they're trying to evaluate for you. Second, I don't think that you, as a parent, I do think that there's it's very difficult, right? So, like let's leave COVID vaccines aside. Let's move to the childhood vaccine schedule.
I do want to ask one follow-up question before we expand on the other, MMRs and all the rest. So there's death, but then there's other stuff, right? That's not death, but is in the middle. So taking the vaccine appears to have increased myocarditis risk with young men. Like my son was of that age in that target at the time when the COVID vaccines were really getting pushed. But what did we know about if you got COVID? Like, so if my son got COVID, survived just fine, did that also elevate myocarditis? Did it elevate myocarditis risks higher than if he had taken the vaccine? Like, this is where the debate on both sides has gotten, like, it's very hard to find anybody that can talk about it in this band of the cost benefit in the gradient that isn't death.
Yeah.
Long COVID, did the vaccines reduce long COVID? Was long COVID even a thing? What do we know now? Does it even matter anymore? Was it all just a scam? Like, but in that gradient, what did we learn about the cost benefit besides the binary of death?
Yeah. So let's just stick with myocarditis and then we'll talk about long COVID. So the myocarditis is the calculus around myocarditis is really interesting. So yes, COVID can cause myocarditis. It did cause myocarditis in people. Absolutely, it did. The question though isn't the relative risk of myocarditis for COVID versus the vaccine. The question is, if I take the vaccine, what's the marginal impact on my likelihood of getting COVID? And what's the marginal impact on the likelihood of getting myocarditis if I get COVID?
Sure.
Right? So
yeah.
Marginal meaning if I take it versus if I don't, what's the change in the likelihood of getting COVID? It turns out that it prevents you from getting infected, symptomatic infection for 2 months, but that declines very sharply after just 2 or 3 months. Right? So it doesn't really prevent you from getting COVID. You're very likely to get COVID afterwards.
I got the shot, the Pfizer shot. I've had COVID twice since, as an example, personally. Yep.
I got the 2 Pfizer shots in April 2021, and in August 2021, I got COVID. It's so the marginal impact on the likelihood of getting COVID, and therefore the myocarditis associated with the COVID is still basically the same. The marginal impact of the vaccine on
because you still so you take the shot and then you still get COVID anyway. So whatever COVID was going to do to you, it's still going to do to you.
Yeah, it's
Or
like two draws on the myocarditis, slot machine, right? So, I mean, COVID is it's a terrible thing, right? It's not like it's nice to have COVID. I wish we didn't have it around, but that doesn't buy us anything, right?
right.
Um, okay, so there's that. I have to say, I think for young men, the risk of myocarditis from the vaccine is higher than the risk of myocarditis from COVID. For older people, it's less.
Really? So it really was the
Yeah.
case that if you gave your teenage son the shot, you were perhaps putting them at a higher risk of myocarditis than just letting them go play basketball and get COVID from their buddies sweating on each other.
Yeah. I mean, there's a lot of arguments in the literature about this, but somewhere between 1 in 2,000 and 1 in 10,000 of young men who got the vaccine, COVID vaccine, got myocarditis. I mean, that's too many,
Yeah.
especially since the benefit from the vaccine for them was minuscule.
Yeah. Okay. So then what about long COVID or these other sort of
So long
lingering
COVID is a little more
symptoms?
complicated. Originally, it's defined as one of like a list of long series of outcomes defined by the WHO as one of a long series of outcomes of persistent conditions that after you get better from the acute phase of COVID, it persists, right? So, for instance, fatigue or
Yep.
brain fog, which you can't think clearly, or actually, this is some of the symptom I had when I got COVID. I couldn't smell,
Yeah. Or couldn't
and
taste.
couldn't taste, right? So, if it persists for 1, 2, 3, 4 months afterwards, that's how people define long COVID. Some of the symptoms on that list are just very common things: headaches, fatigue is actually quite common, especially if you're like me, you don't get enough sleep. So long COVID is one of this list of symptoms, and there's like different groups of people, right? So, for instance, if you had very, very severe COVID disease and you ended up in the ICU, it's going to take you a long time to recover. Everyone who comes out of the ICU, it takes them a long time to recover. That's just normal for going in the ICU. If you get the flu, you can sometimes get these post-viral syndromes that last a long time. My son, when he was little, he got the flu. This is like in 2015, and one morning, the day after he got better, he woke up and he couldn't walk. And I thought I'd like
my
50.
God.
You go to med school, it's very easy to run through really catastrophic things in your head. It turns out it was something called benign myositis, like inflamed muscles, and within 3 days later, he was running around the house again. Right. So those things happen, right? Those things are happening. Those are real. There's nothing. I mean, those are physiologically they occur. But at the same time, also during COVID, we locked people up. We made them depressed. The list of symptoms that the WHO had for long COVID included things that the lockdowns could cause.
Yeah. Like
Even
fatigue associated with depression as one example.
Yes. So it's a scientific question how common it is for those different groups. And I just want to be clear. I'm not saying that long COVID isn't real even in that third group. I mean, those are real symptoms that people really do experience. The question is, how common are they and how related are they to COVID versus other things? So there were a series of studies that were done, like in France, I think I saw one, in Israel, a few other places, that compared people that had COVID matched with people that didn't ever have COVID early in the pandemic, and then they tracked how many people reported having those symptoms. In children, the rates of kids having some of those symptoms, one of that long list of symptoms, fatigue, so on, in the matched control group and the COVID group were almost identical.
To the extent that study was measuring reality, it suggests that the vaccines were functionally useless for kids for either death or extended symptoms, but did subject them to unknown future risks because it's new technology and you're injecting your kid with something and we don't know what the outcomes are going to be. So precautionary principle seems like a natural fit for that situation.
Just recently, in the last 6 months or so, the FDA published a study that found that 2 to 4-year-old children who got the vaccine, there was a signal of elevated risk of seizures. So, okay, so I think it was unwise to ever recommend that young people take this vaccine. It was pushed on the premise that it would stop you from getting and spreading COVID. But
Right.
as we said, the randomized trials ran for 2 months. They didn't check whether it stopped you from spreading COVID. They could have, right? So, for instance, you had a vaccine arm in the trial and you had a control arm in the trial. They could have asked whether what's the likelihood of getting COVID for the vaccine arm, the spouses of the people in the vaccine arm, the spouses of the people in the treatment arm.
Oh, interesting.
And if
Yeah.
it stopped you from getting spreading COVID, then the spouses of the vaccine patients should have lower rates of COVID than the spouses of the people in the treatment arm. But they didn't ask that question in the trial. So we didn't know from the...
Wait, so why didn't they ask that? I'm sorry if I'm visibly angry. Why would you not ask that?
I don't know the answer to that question. It floored me when I saw that they hadn't asked that question in the trial.
Okay, so
but it is what it is, right? It's December 2020, and you have this trial result. In public health, you can't in this situation guess. You can't say, "Oh, I wish that it stopped people from getting COVID and spreading COVID," because you're about to make a policy that says, "I'm going to force everyone to get COVID or get the vaccine, or else they can't live their life normally." On the premise that if we could only get everybody vaccinated, then the disease will go away. It turns out that we did not have the scientific basis for thinking that in December of 2020. We've never had the scientific base. And it turns out, as the evidence came out over the course of 2021, it became clear that it wasn't true. Even if 100% of the population was vaccinated, the disease would still continue to spread until the end of time.
I want to ask one more question about the COVID vaccines before we talk about other vaccines and how to think about that, the risk benefits for other vaccines. And that is, there is a claim that seems like it might be a failure of numeracy, but I'm not sure, which is the claim that, well, the vaccines are terrible because the rates of COVID are actually higher among the vaccinated. I've heard this phrase. It has been thrown around. How should I think about that? What does that, is that getting causality wrong? How should I think about that phrase?
Okay, so it's complicated because most of the results that have those kinds of outcomes are not conducted in the context of a randomized trial. So the set of people who choose to get the vaccine look very different than the set of people who choose not to get the vaccine. Actually, the vaccinated, they look on other bases, they look healthier in general than the people who choose not to get vaccinated. There are real results that I believe are true. So, for instance, the first 2 weeks after you get vaccinated, you're more likely to get COVID. I mean,
is that because your
are.
immune system's depressed, or we don't know the mechanism?
We don't know at least I don't know the mechanism,
Okay.
but I think it has to do with your immune system is like, disturbed, and in the meantime you're not yet protected against COVID. It might also be selection. It could be that once people were vaccinated in April 2021 or January 2021, they're like, "Oh, I'm free and I can go."
They take more
out.
risks.
Right. So it's a very complicated question. There are some studies, which I don't know if they are representative of the population at large, but are concerning about what COVID vaccines can sometimes do to some, I think, relatively small number of people, but still to some people, to the immune systems of some people. And so it's possible that result is true. But I don't know from the literature, my reading of literature, there is not a sufficient body of work that has convinced me that I know the answer to that question.
What about the fact that over time, a huge number of people got vaccinated, and that changes the ratio by definition of how many people are going to get? If 80% of the population has gotten vaccinated, then of course more people are going to get COVID, since the vaccine doesn't prevent getting it again. Is that a
Absolutely.
decent rough heuristic here to be like?
And let me add one more complication, which is that this is a virus that evolves, and it evolves to the fitness landscape around it. So if most of the population is vaccinated, it will evolve to evade the immunity of the vaccine.
Right.
That will select for the versions of the virus that evade immunity of the vaccine. So it's going to be a complex, dynamic thing, and so there's not going to be a simple answer to your question. What I can say very simply is that the vaccine does not stop you from getting and spreading COVID. That means that whatever you think COVID is going to do to you, it's going to do it to you whether you get the vaccine or not. The marginal impact of the vaccine on the likelihood of dying, that's really important, right? And it does actually reduce, at least for 6 months, the likelihood of dying the first time you see COVID. So again, I think after that it starts to diminish. The boosters do not have, in my view, the kind of randomized evidence that would allow me to give any confident recommendations whatsoever. And in retrospect, I think they should have been reserved for only the most older and vulnerable people and nobody else.
My son was in school in September 2020. His school didn't even want the kids to wear masks. They were like, that's a waste of time. That's obviously nonsense. Obviously, if you have 2 brain cells and you look at the way kids behave, no chance masks are going to do any good. So that was the walk I walked with my family. There is this question, though, about what to do more broadly with our kids and with vaccination. And I, in general, maybe it's just because my dad's a doctor, traditional MD, I have usually been like, I ask my dad, what should I get? He says, get the standard kind of thing. And I go do it without much reservation. When we had our son, my wife was more skeptical. And so I, going all the way back, my son's 19, I looked into this thing of, well, do vaccines cause autism? Which was a claim. I was even in my doctor's office because we had sort of a little bit of a crunchy granola doc, which my wife picked. And he was telling a patient, vaccines cause autism. Do vaccines cause autism?
Okay, so first of all, let me unpack that question, right? So there's multiple vaccines, many of them. And the question is not, do vaccines as a class cause autism, but do the particular vaccines that are recommended to be given to children cause autism?
Yeah, like measles, mumps, rubella, and such.
Right. You answer the question one at a time. Now, the idea that the vaccines cause autism actually came out of the first time I'd heard of it was a study in the Lancet, which is a very famous British medical journal. A small, tiny study with, I think, inadequate kind of methodology that found that there was some correlation. It's the kind of study that would normally be published in some journal no one's heard of, and then there have to be much larger and larger investigations before it was studied. But it was published in a very top medical journal, and it caused a lot of people to think that the MMR vaccine, measles, mumps, rubella vaccine, causes autism. Now, work that has been done subsequent to that, not randomized work, but like large-scale population epidemiological studies of the sort that I deem as credible in the Netherlands by groups that are not conflicted, have found no correlation of the MMR vaccine and subsequent autism using population-scale data. So I don't believe the MMR vaccine causes autism. Now, it's not randomized, so I tell my friends who are much more skeptical of vaccines than I am and they're like, well, it's not randomized. And my answer is, yeah, right. Yes, you're right. It's not randomized. I wish we had a randomized study that concluded that, but it's hard to conclude a negative from a randomized study sometimes, and so we don't have that. It's also hard to convince doctors to run a study for an intervention like the MMR vaccine that almost every doctor believes is worthwhile to do, and then say, okay, I'm going to randomize some kid to not get it.
Right.
That would be deep.
So I understand this to continue, because the listener who's skeptical, who's made it to this point and is like, okay, now we're getting into the stuff I'm worried about for my newborn. If most doctors believe MMR will prevent measles and mumps and rubella, but measles is pretty, like, these things are not good things. They can be quite harmful. Not giving kids the shot feels like it might be almost child abuse. If you believe as a doctor that this will prevent kids from getting harmful diseases, and it works and it's well established. So to do the right, is that right? So to do the control trial, you'd have to intentionally follow kids that go unvaccinated and see how many of them get measles, mumps, rubella versus the vaccinated set. Is that right?
That's exactly right.
And no one,
it would be
very few have been
that
willing to do that, or nobody's. Has anybody been willing to do that?
I mean, what would happen is you go to if I were to propose such a study, and I wouldn't because I'd work on other things, but like if I were to go to try to propose such a study, if I could get funding for the study, I would have to show it to a human subjects review board, whose job it is to protect the subjects of the study, and they tell me that it's an unethical control arm, that I'm not allowed to run the study. Okay, so that's
Okay.
that. But so the next best thing are these large-scale, population-wide, carefully controlled epidemiological databases where you match people that are very similar to each other at similar ages. Just in reality, some people don't get the vaccine, and you track them prospectively and see what happens to them. I didn't tell them not to get the vaccine; they just happen to not get it. I capture them in my database, and I go forward and ask, are the kids that were vaccinated more likely to get autism diagnoses later on than the kids that are not? And large scale studies in Denmark found in the year 2000, no, the answer is no. They're equally likely to get an autism diagnosis. There are more complications here than this. So let me just tell you a couple of complications.
Okay.
So one, measles, mumps, and rubella are very bad if kids get it. It's bad for kids to get it, right? It can cause death in the kids. But it's very uncommon, in part because of the success of the vaccination programs. So the marginal benefit in a population that's largely vaccinated to any particular child getting vaccinated is actually small. But if everyone were to choose to do that, then measles, mumps, rubella would come back, and you would have the marginal benefit get higher.
So
right?
what you have is I can choose not to get the MMR and go, and my risks are low because I'm free riding on a herd immunity because most people get it.
Exactly. The other aspect of it is there's a very talented epidemiologist in Denmark. Her name is Christine Stabel-Ben. She has done some really interesting work asking whether vaccines that are live attenuated vaccines, what impact do they have on things that are not targeted by the vaccine in terms of the health of the child? And it turns out that in her work, live attenuated vaccines reduced the risk of mortality from other diseases, not just related to the thing that you're supposed to protect. Like, so for instance, the oral polio vaccine, which is not the version that's given in the US, is given in Africa. In her work in Africa, finds that it reduces all-cause mortality for children in randomized studies that get the oral polio vaccine versus who don't. Other vaccines that are not live attenuated vaccines do not have that result.
What does
So
that
the
mean,
DBT
live? You
vaccine,
mean like the virus is alive instead of dead?
Yes.
Okay.
Right. The virus replicates inside of you. So there's like two kinds of vaccines. One kind of vaccine, you give a pathogen that's similar to the thing you want to prevent, that's still live. You get a mild version of the sickness, and then you're better. And then you're now protected against, if you were to get, if you're subject to polio, then you're not going to get it because you've already had that attenuated version of it. The other version of the vaccines are essentially dead parts of it. So that's what the COVID vaccine is an example of this. It's not supposed to, it's just producing the spike protein. It's not producing live virus that can replicate inside of you. And it trains your body to react to that part it's exposed, not to the entire live virus, right?
So to take a step back for just a second, how do vaccines work? For the person that has never heard this before, how does a vaccine work?
Your immune system is this incredibly complex system. And it's when you're born, it's necessarily not specialized. Its job is to make sure that you don't die when you're exposed to the pathogens in the world. And what happens is there's all kinds of parts to it. There's like the B cells and T cells. What it comes down to is there are layers of defense so that when you are exposed to a pathogen, you can neutralize it either with antibodies or other cellular immunity that go find the infected cells and like destroy them. So that when you are infected, the pathogen causes a self-limited infection that then that you recover from. Your immune system is amazing in the sense that it learns every time you face some pathogen or some thing from the environment, it learns to deal with it. It has to tell the difference between you, because it doesn't want to attack your cells, and foreign cells, foreign pathogens. When you're a baby, you get sort of passive immunity from your mom, first in the placenta, and first in the womb, and then second through the breast milk. But your body over time, your immune system over time, starts to learn how to deal with the kinds of threats that it faces through its life. And as you get older, you get more and more specialized in the set of things that you can deal with. The way a vaccine works is by introducing sort of challenges to your immune system that essentially tell it, look, you should be able to deal with things like this. So just to like stick with polio, right? You give a live attenuated polio vaccine. That's not polio. It's a version of the polio virus that's been weakened, so it's much less likely to produce paralysis in you and all the really bad outcomes. The next time if you actually do see polio, your body says, "Oh, I've seen something like you," and then neutralizes it before it causes all kinds of bad things. Right? That's how roughly a vaccine works.
So it's functionally exposure therapy.
Yeah, that's exactly what it is. Actually, it's exposure therapy.
It's funny because we've talked to a lot of psychologists, especially in cognitive behavioral therapy psychologists, and they apply the same technique, with success especially for PTSD patients to behavior. Oh, I get literally triggered when someone slams the door because I came back from Iraq. Well, let's work through that. And part of that working through it is being your door slamming and realizing you're not going to die, and training that fight or flight system to realize that you're not at risk when you hear a door slam.
I mean, it's similar in that way, except it's your immune system that you're doing this to. It's much more complicated than that. There's like there's a different kind of immune, like this passive immune system and an active immune system that are two distinct systems. There's immune systems that are like in your gut, in your nose, and all through your body. They interact in complicated ways. It's actually, I mean, if I'm going to use like religious language, it just looks to me like a miracle. I mean, it isn't a miracle. I know it's like biophysical in the sense that it's natural, but it's still in effect miraculous. Yeah, because like there are pathogens literally everywhere you look. Your skins are filled with pathogens. Even if you wash your hands all the time.
What I've noticed, this isn't saying anything that isn't obvious, is the politics of the COVID lockdown and pandemic has resulted in extreme vaccine skepticism for people who think the government sucks and thinks this is all a scam, and that, the radical left is trying to silence all of us. And I'm not saying any of those things derisively. I believe all of those things to be true. What I don't believe is that all vaccines are a scam. And how do I know I'm right? How should a parent who is skeptical navigate the information landscape in 2024 for their family, for their kids? What is a way of thinking about the medicines I should give my kids and myself to ride the cost benefit line in favor of benefit?
I think it's completely reasonable for parents to ask questions of their pediatricians and of the public health authorities. I don't understand the sort of like rejection as if they were heretics just because a parent says, "Well, what's this doing to my child?" Right? And I think it's also reasonable for the kinds of responses that they get to be sophisticated responses. They shouldn't just be, oh, just trust me, right? I think that they should say, like, someone who tells you, I don't know this, but I do know this, then allows you to make the decision I think, is much more trustworthy than someone who says, oh yeah, you go away, it's safe and effective, without telling you why they think that, right? And the second, I think that it's also reasonable to ask questions about the particulars of the vaccines that are on the schedule one at a time. Like, I don't see how in this post-COVID era you can just simply say, trust the experts. But I will say this: I do think that if I had a young child now, I would give them many of the vaccines on the schedule. I'm convinced. I know there's uncertainties around all of them, but I'm convinced by the historical use of them and the data that I've seen so far that they're reasonable and useful for my children. There are ones where I'd be more skeptical. I probably would give them, but I totally understand a parent saying no, right? So, for instance, there's a vaccine that prevents cervical cancer, the HPV vaccine.
Yeah.
And, well, it's a sexually transmitted disease in that sense, right? HPV is generally sexually transmitted. Why give it to a baby? Someone could easily ask that. Do I need to give it to my son who's not ever going to get cervical cancer, right? Their hepatitis B is another virus that babies, unless they're exposed from the mother in utero, are not going to get the disease until they're an adult. Could we wait? Right? Again, I personally would say fine to it, but I can totally understand a parent saying, no, let's wait on this. I think having a pediatrician that's willing to work through your questions is a very, very important part of this. And finding somebody that treats you like an adult, the parent like an adult, is really also an important part of this. I don't think it's sufficient anymore for public health to ask the public to take their word as authority without allowing questions. In fact, turning people who have questions into heretics and sort of telling them that they're, sort of bad guys because they're asking questions. I think there's no longer, it should never have been a legitimate kind of tactic by public health. So that's how I would approach it as me personally as a parent. I mean, I should tell you, I share your bias in a sense of, like, I was trained in medicine. I worked actually in hospitals in rural India, where I've seen some of these conditions that the vaccines prevent, and they're bad. And I don't want that. And I think one of the major successes of medicine has been to reduce the prevalence of diseases like measles, like polio, to relatively rare, to be very, very rare, especially because of the vaccines. And they're not eradicated, they're not gone. They could come back if the vaccination efforts were to go to zero. There's a disease like smallpox that through vaccines and like lots of other efforts, the disease is gone. And so we don't vaccinate anybody with it anymore, except for, I think, military personnel.
Is that because there was enough risk with the vaccine that the fact that it's been eradicated means the risk of the vaccine is now higher?
Exactly. Right. I mean, I think there was a death rate somewhere between 1 in 100,000, 1 in a million for the vaccine. And there's no death from smallpox anymore because it's not spreading in the population at large. So, yeah, so there's no reason to vax. So for each vaccine, they should be revisited. The cost benefit ratio should be revisited. I mean, the benefit harm ratio should be revisited over and over again. And if you have a child with specific conditions like that make you think that the child is likely to end up with a bad reaction to the vaccine, they've had a bad reaction to the vaccine before, then you should revisit that. It's going to be a personalized thing. I will say one other thing because we started this discussion with autism. It is a huge problem for parents that autism rates are going up. It's a huge source of anxiety, and it is something I don't know why it's happening. I mean, I've read as much as I can of the scientific literature. This seems to me like there's a lot of uncertainty in the scientific literature about what is the cause of it. One hypothesis is just we're like diagnosing more of it, and it's always was there. I don't believe that's true from my reading of the literature. I think there's a legitimate increase in autism in the population at large. And the question of why is we should be moving heaven and earth to answer it. And I don't think it'll likely end up being the vaccines, but I don't know that for a fact. So it should be part of the scientific conversation of as a hypothesis that looks at, because we are asking parents to vaccinate their children with several vaccines, many vaccines. There's one, I forget, I've lost track exactly of the total number. Each of them could have a different combination of effects, right? Right. So if you have two vaccines,
one thing we did was we didn't get all the shots at once with our son. We spaced them just on an intuition, and this was all my wife. So credit to her to the extent this was a good idea. Like, why hit your immune system with all these different things at the same time? If I can space them out, what difference does it make? And it was weird, actually, the amount of pushback we got. Like, why do you want to do that? It's like,
yeah,
well, why not do it? Like, why wouldn't I want to do that?
Yeah. I mean, there's not great randomized trial evidence to like answer that question. So why not just have that? Especially since measles isn't really circulating at very, very high levels in the community at large, right? So you're not actually exposing your child to a risk if you delay by a couple of months. If it is circulating, then of course you'd probably want to do it earlier, right? I don't know that autism is caused. I suspect, I mean, if I have to guess, and this is just a guess, that the answer won't end up being vaccines. It'll end up being something else in the environment at large. And we really need to find out what it is and address it as rapidly as we can, because what's happening is, first, there's lots and lots of kids that are suffering from this condition, parents and families that are suffering from this. And we need to figure out ways to both manage it better so that they get support that they need, and also to prevent it if we can learn to prevent it. But at the same time, it's also causing lots and lots of parents to say, I don't want to deal with the vaccine schedule.
Right.
And if it turns out not to have been the vaccine schedule that's the cause, that will be a tremendous cost that we've imposed. So I think it's going to end up being a complicated thing. I think the problem for public health is that the history of public health, vaccines have played such an outsized role in the prevention of disease, really bad diseases. And some of the most important success stories in public health have involved vaccines. And so for public health officials, they just want to say, this is right, this is good, this is safe, this is effective, far beyond what the evidence actually says, rather than the nuanced kind of conversation that really we should have with them, with parents. And I think that in the post-COVID era, that kind of communication strategy is going to backfire, has backfired, will continue to backfire.
You made a very nerdy reference earlier in our conversation to something people probably didn't pick up, which is you referred to the Virginia School. I happen to know what you're referring to. This is economists like James Buchanan. They're known as the public choice economists, who say, hey, it turns out that government is filled with humans. And since economics is about the study of how people respond to incentives, why don't we bring the economic way of thinking to the humans in government and how they respond to incentives? Would you say that's a fair description of the Virginia School?
Entirely right.
So what we face now is a world in which our politics and the politicians and the humans that are in and appoint these government experts that have particular monopolistic power relative to just private health med down the street is a bunch of incentives and dynamics that seem poisonous and corrupt and unresponsive to even the most extreme failure we've ever seen in our lifetime. We've had this extreme failure. It's manifestly a failure of policy. The political system seems unresponsive to it. The sort of bureaucratic blob just thinks we're all a bunch of rubes that need to shut up. And that's where we are. So I'm talking to my doctor and trying to get a nuanced conversation. And my doctor faces this whole other ecosystem of medical liability and Obamacare regs and what they might be getting paid for recommending or not. And is there any path away from such a government-controlled healthcare system, in your view? Do you see, as a policy expert, a path towards less government? You talked about decentralization, but to actually get politics out of my doctor's office, is there hope for that? It feels like this should be the biggest thing being talked about post-COVID, and yet I don't see it talked about anywhere. Like, get the government out of my doctor's office.
I mean, I wrote a health economics textbook. Actually, kind of, it's if you read it, you wouldn't say it's exactly on that theme, but it was actually on that exactly on that theme. The question is, why are governments involved in healthcare at all? And there's an economic answer to that. So the economic answer is that there are a deep range of uncertainties about our health, some of which require tremendous amounts of money to deal with. Right? I get cancer. If you just ask me to pay out of pocket for the treatments of some of the really rare cancers, I'm not going to have enough money to pay for it, and so I need to get insurance. There's the technical term is that the distribution of medical expenditures is right skewed. Right? There's a tail of expenditures that is that it's low probability but very, very expensive, and if you get it, you want to have insurance to cover it, because even if you go bankrupt, you're not going to be able to cover it. A young, healthy young man has no desire to pool with me in health insurance, because if I get sick, he'll end up paying for it, and he's much less likely to get sick. And so the insurance markets tend to do poorly in providing coverage for those rare outcomes, but that's exactly what that costs money in a expensive healthcare system. There's another problem, which is that if I do have that insurance, I'm going to go get stuff that I probably don't need because it's relatively inexpensive to me.
So this is moral hazard, right?
Moral hazard, exactly.
Oh,
so these
I'm covered. I'll take two.
Exactly. So you have these but at the same time, if you have the government do it, right? If you have the British NHS, the government just pays everything, $0 at the point of service. You're going to have the moral hazard problem in spades. You're going to have,
because everything's free, so I'll take two. It's like when Obamacare. I remember there was this Oregon study in the about Medicaid and Medicaid expansion, if I remember this correctly. This is going back a little bit, so correct me if I'm screwing this up. But the study in the aftermath of Obamacare, which expanded Medicaid coverage, and thereby, for those who got on Medicaid, they could go to the ER and not get a bill or not get a substantial bill like they used to, which sounds great. Oh, you're a working class or poor person. You got to go to the emergency room because you're sick, and now you won't get a bankrupting bill. Okay, well, the claim was somehow that this would reduce the utilization of ERs. Why making a thing free instead of expensive would reduce its use is maybe because there's not enough PhDs in economics and health policy. But of course, that's not what happened. People that got on Medicaid used the ER a lot more. And the Oregon study found that actually those people didn't even end up with better health outcomes than those who didn't get on the Medicaid. And instead of going to the expensive ER and have taxpayers pay for it, they did other stuff, which also got them better. And so that study to me represents a pretty robust counter to this theoretical claim that, insurance markets can't work because of all these information asymmetries and blah, blah, blah. Government failure seems like it swamps market failure every day of the week and twice on Sunday. So I know I'm being super ideological here, but I'm also not, because I think that's what happened. Make the argument, argue against that.
So I'm not sure. Are you? Let's just reason together, right? So the Oregon the Oregon Medicaid experiment is super interesting because it actually was an experiment. Oregon, this is crazy. It's going to sound crazy to people listening to this, but they randomly assigned who got Medicaid in the expansion group. So it was a randomized study of insurance coverage.
Right.
There's actually history of this in health economics. The Rand Corporation in the late 70s ran a randomized trial where some people got basically free care for 5 years and others got 95% copay, basically no insurance for 5 years. And they tracked it. The people in the free group used more care, but did not end up with lower mortality than the people in the 95% basically no insurance group.
Yeah.
Same thing happened in Medicaid for Oregon. So, and actually there's one like tweak to that. So I think like people with mental health problems did better in the in the Medicaid, they got Medicaid arm than a non-Medicaid
They
arm.
were less worried about their bills.
Well,
I think that's actually one of the findings, that financial stress went down, which is sort of
yeah, so that's true.
tautological. But
There's two ways to view this. Your view was that it's a failure of government because it's government insurance. Another way to view it is that the medical care system, what it provides is not primarily prevention of death. It's providing something else. Financial peace of mind, the idea that if you're sick, some kind smart person is going to look after you and think about you. It's providing something else, at least in the United States, beyond just the prevention of death. You mentioned the problem of government provision of health. Like the NHS is a good example. The UK NHS is a good example of this. Right there, you have this moral hazard problem that we just talked about. You have this problem that you pay nothing at the point of service, and so people will want to line up for all the services. They solve that moral hazard problem, if solve is the right word, by queues, by asking people to wait to get care that in the United States, if you have insurance, you'd say, why would I want to wait 6 months to get cardiac catheterization to clear a clot in my heart, right? In the UK that happens, and actually in the post-COVID era, it happens all the time. Fundamentally, this is just my philosophy. I think that there is no utopia, that cannot be, that there are these deep uncertainties, and neither governments nor markets can automatically solve them. Markets sometimes solve them really well. I mean, I tend to think that as an economist, and governments can certainly often screw up, but markets do have the problems, and governments do have problems, and we're always going to be muddling through. Is my philosophy of the way the world works. I tend not to get excited about the ideological kinds of, because it's, to me, everything is like, well, let's parse the data and try to see what's working here. I don't know of an answer that works across the board, if you will. I do think there are ways we can improve markets in healthcare systems. And it's actually shocked me that the American healthcare markets have not adopted them, right? Insurance companies have a very strong incentive to make sure that you should only get the care that you really, really will provide value to you, and not give you care that does nothing for you. But they're really bad at that. They're really bad at rewarding doctors that are wise, that give you good advice, that give you good outcomes. We pay for the services you get rather than the outcomes you get.
Yeah,
the price system doesn't have to be structured that way. That's a really weird market way for a market to be structured. Why doesn't the market restructure itself so that it pays for outcomes rather than for services?
It seems like if we had rational expertise, that one way you could solve for this and end up in a better muddle than we have, it wouldn't be utopia, but it seems like it would be better, is for the federal government, maybe just at the state level, but let's just say federal government, to basically provide everyone with what looks like catastrophic health insurance. So we're not going to pay for anything up until a certain threshold. So you got to come out of pocket for it, which means you got to care about how much it costs, which means you've got to negotiate and pick places that are giving you a good deal. But if you end up with leukemia, or you get hit by a car, or you get HIV/AIDS, or one of these things that, is going to be really expensive and is that tail that you were talking about, you're not going to go bankrupt. You're going to be backstopped. That's fine. But what we're not going to do is sort of take over the whole thing and micromanage every single decision everyone makes about everything, and tell you, oh, we're going to cover breast pumps when you get pregnant, even though you've had 9 months to save for a breast pump, definitionally. That feels like something that irrational left and right in the before times could have been like, okay, yeah, you know what? Not this super top-down picayune telling us which procedures to get and which are good. No, we'll just backstop you so you don't go bankrupt. We'll spread that cost across the whole population. That's insurance. And then figure it out, and then you'll get the best of the 1950s. And I say that because, I said before we started, my grandfather was a doctor and my grandmother. And I went back and looked, and you could get the full cost of delivering a baby in 1950 was like $1,200 cash. It wasn't covered by insurance for reasons that are obvious if you understand insurance, which is to say, it's not rare or unforeseen. I know why it happened. I know when it's going to happen. You can't insure me against it. I know when it's happening. It's like saying, can you insure me for the car wreck I'm going to get myself into tomorrow? It's like, no, I can't. Today, that same set of procedures, even with all the insurance, is even more out of pocket than it was in 1950 in real dollars, in present dollars, inflation adjusted. So it seems like what most of all this inflation and protection has done has basically been to pay for a bunch of unproductive medical services and drive the cost of all of it through the roof, such that we aren't even getting more care when we need it. We're getting more expensive care, and we're still coming out of pocket for it, and we're paying more in taxes and we're paying more in premiums. Is that a fair characterization of the system, or am I trapped in my own ideological bubble?
No, I think both left and right agree that is a fair characterization of the system. And if you squint, left and right also agree with your sort of like broad solution, actually. The only fight is over where do you draw the line and say, okay, we want to cover versus we don't want to. It should be left, and the left tends to be more expansive in the set of things it wants to cover, and the right tends to be maybe less expansive. I mean, I'm painting with too broad a brush, but that's roughly speaking. And so I think the question then is just a matter of like where does it belong? But I think the key thing to me is the cost problem. It is extremely expensive, especially in the United States. We spend almost $1.05 of national income goes to healthcare. That is way too expensive for what we get, and it's the root problem of and you also have like, I don't know, 30, 40, 50 million people who have sort of less insurance, but basically don't even have that catastrophic insurance. So we're spending all this money, and and you have a large chunk of people that don't have it. The central problem is the cost, right? So you had Obamacare. What it tried to do is expand who got insurance. The Medicaid expansion was the most important part of Obamacare. It was called the Affordable Care Act. It wasn't called Obamacare, right? But it did nothing for actually making care affordable. Care has gotten much less affordable since Obamacare was passed. In fact, the structures that are in place, it's systematic almost that it would produce that kind of outcome. Like it's more capture of the regulatory structures by powerful entities like health insurers and pharmaceutical companies and so on. And so the market is less efficient, works less well. And so you have this, it's as if the one thing we want to solve, which is let's give most people that this peace of mind about this like catastrophic outcome. Well, until you solve the cost problem, we're not going to be able to afford to do that, right? You won't. I think 11 states still haven't expanded Medicaid on the Obamacare role, and so it just seems to me like the entire conversation, both on the left and right, it's missing the key thing. And you're the way I love how low you characterize it, John. I mean, because what it does is says let's talk about that key thing. Let's talk about where do you draw the line of what should belong in the catastrophic bin and not. And then I would add one more thing to that is how can the market price the things that really we pay for care for, right? I don't really care about the drugs I'm taking. What I care about is the outcome I get from taking the drug that I take or don't take. And so if a doctor comes and gives me good advice that says, Jay, you don't need that surgery I would give you, and they get a good outcome. I get a good outcome as a result of that. That doctor ought to get paid at least as much or more than someone who does the surgery. If markets could change what they pay for And it's actually a real mystery. I've been studying health economics for decades. I mean, I know almost 3 decades now. And I don't understand why markets do not move in that direction much more forcefully, other than that there are entrenched interests in government and in markets that benefit from the current structure that resist the movement to that an equilibrium like that.
One of the pieces of the puzzle that I looked at in the past, and I'm sort of dredging some of these things up from memory, because the real tragedy is this debate, even this conversation you and I are having, it's nowhere to be found in our public discourse right now, as far as I can see. No one's talking about healthcare policy in a way that is trying to get at root problems. Which is bizarre. I mean, we're in an election year. I don't even know do the candidates even have proposed plans for any of this? I haven't heard it. It seems like we have this system with Medicare, Medicaid spending at least half of all of the medical dollars spent. They have this mechanism of paying for procedures with all these crazy codes. And so everything else necessarily orients around whatever Medicare or Medicaid does. Just like if California says, well, you need to have a platinum catalytic converter on your car, Detroit's going to make cars that work in California for all 50 states, because what am I going to have, California cars and Texas cars? No, I'll comply with California, because otherwise it's too expensive to have two different product lines. And it seems like that's what's going on. I mean, do you think how much of the things we see as market failures are just the market not wanting to run two parallel systems?
I mean, there's certainly some aspect of that. I have to say, I don't fundamentally know the answer to either of the questions you just posed, which makes it a funny thing. I mean, I think the political system.
You got the PhD.
I don't know. I guess I'm better at saying I don't know than most PhDs. I think the political discussion over health policy is just unreal to me, and it has been since the Obamacare debate. In one sense, was a real discussion. It led to, I think, evasion of the critical issue: why is healthcare so expensive, and what to do to fix it. And it tried to band-aid it over with this patch of expansion without addressing the cost problem at all. And so predictably, it has failed. Except for the Medicaid expansion, which is tremendously, it's still quite inadequate given how many poor people don't really have the catastrophic care we're talking about.
Well, the closest analogy, it seems like, to it is, hey, we want more people to go to Stanford University. Let's provide all kinds of cheap loans for them to go to Stanford University. Oh, Stanford University still likes to tout the fact that not many people can get in, but now there's a lot more loan money subsidizing the tuition. So I guess we could raise the tuition, right?
I mean, I know that I love that analogy. And what's happened is that that debate basically was the last time we had a real honest healthcare policy debate. I think there was like the Bernie Sanders thing, which tried to say, let's have single payer, as if the US could possibly have like an NHS-like system. And the NHS has its own problems. It'd be importing a system that I think is alien to the United States. Almost 200 million people get health insurance through their employer, and you're going to take that away from them. The kind of care that they normally used to get is going to be reorganized entirely. I mean, I think that's just a political non-starter. It doesn't make sense in the context of the United States. It may make sense in the context of the UK, but it does not make sense here. So, and since that, we've had no real political conversation over the right health policy. And COVID, I think, it's just made things completely. It's an unreal thing. Huge numbers of people don't trust their doctors anymore.
Yeah.
Huge numbers of people don't. I mean, the healthcare system is at large. I've never seen trust so low. The pharmaceutical companies are in disrepute. Governments are in disrepute. We have real problems that I don't know how to solve in terms of restoring trust. And then after that, like, how do you do the fundamental reforms of the healthcare system so that they work again, work for maybe for the first time? That's a conversation we should be having, but are not.
One piece of optimism is that you have not been run out of town. You are still out in the world. You are still at Stanford. So in otherwise just reputation damage that should be, laid upon your institution, they at least didn't kick you out. So that's the faint backhanded praise I can give your institution. Where do you see the most optimism? Where are you the most positive about the future?
John, I think there's a coalition of people, and it's growing in size, who understand that the pandemic response was a catastrophic failure. Now, that seems like a strange basis for optimism, but I think it brings that idea that we've had this failure of experts in this way has brought together a potentially large political coalition waiting for some talented politician to tap into it. And also the will and creativity to reform elements of the system that so clearly are broken. And so that's where my optimism is, like seeing the grassroots movement that toppled the vaccine mandates for OSHA, for instance, or the pushback against child masking when it made no sense, the push to open schools in places where they tried to keep them closed. I think that those kinds of coalitions that united people that were on the left and on the right. I mean, we started the Great Barrington Declaration with people from the left and right have come together. I find that tremendously heartening. I love economics, and I love Hayek, and I love the Virginia School, and I love thinking along these lines. But I'm not a particularly ideological person, and I love to learn from people that disagree with me ideologically. And I think that that's happened to a degree I've never seen it in my professional career during the pandemic. And I think that is a cause for much optimism.
I ask this question of every guest, and with you and the role you've played in all of this, I think it's especially heroic. I say that we named this Dad Saves America because I believe that as a man, this is a role we get to take on in our lives where our agency matters and where we make a difference, and that difference starts with our kids and our family. You feel it in our community, the people we know and connect with, and that if all of us do that, it will change the country. That is how we save America, one family at a time. And that is a heroic role we play. How do you think about your role in the big picture of the American story?
Well, first of all, I am a dad, so there's that. And I think that is my most important role, husband and dad. I think that if everyone embraced that philosophy, we'd have a much better society. Not all problems wouldn't be solved, but like many of them that are there would be solved. I didn't realize this about myself, but before the pandemic, I thought I just was a scientist that just tries to say what I see. That's why I still think of myself that way. What I didn't realize was how important that actually is. And that's really the role I think of myself as playing in solving things. I'm going to just keep saying what I see. People may or may not pay attention to me. I may go back to being a quiet scientist, and that'd be just fine. But what I see now is that is that role of the academic saying honestly what they see, including their uncertainties, is tremendously powerful. And I wish more academics would actually just did that. I wish public health did that. I want to play a role in the reform of public health systems in this country. I want to play a role. For decades, I've wanted to play a role in the reform of health policy, so that everyone can be taken care of in a better way. Whether and I think that if there's one cause for hope I've had from the trauma of the last 4 years, is that I think I'll be able to play that role much more effectively than I did before the pandemic.
Dr. J. Bhattacharya, it has been an honor and a privilege. Thanks for being on Dad Saves America.
Thank you, John. So good to talk to you.